prepatellar bursitis. That is. So it's one of those things you can, wherever you got a bit of a bursitis, could be get one here, back of the heel. Could be, we'll do the ischial, we'll do the top of the hamstring, ischial tuberosity bursitis. Lecrinum bursitis works very nicely for. I mean, you did the shoulder yesterday, you'd be in very close to that bursa. So there's a bit of a debate in the books about whether you should treat bursas because you know there's a slight issue with infection. But I've been doing it for close to 20 years now, and I've never had an issue. And if you keep your hands clean, I think if you use the needles. And don't reuse them, you should be absolutely fine. So that does happen, believe it or not. I see a box of small needles over there. Yeah. Thanks. Thank you. Just flare it up. Sure, you come around this side. Sorry. Okay. Yeah. So we got up to here when it came, so we'll follow up onto the knee now and have a look at all the things you can help out with knee issues. So there's a broad span of stuff you can tackle with this, from sports injuries up to what I find really useful is older patients with just arthritic knees, and then now globally they're becoming aware of knee procedures and outcomes are not marvellous. They're not guaranteed to give you success over the long, medium, long term, like 5 years plus. So anything you can do conservatively to treat something like this and keep people moving, functioning without going drastic. Sometimes you need a knee replacement. If you've got a world of pain, literally you can't weight bear on the thing. There's no alternative. But I'm talking about all this lower grade stuff that should we intervene, shouldn't we intervene? Well, I think you should probably start with this as a treatment option to begin with. So your bread and butter when it comes to knees are going to be the joint line. So you need somewhere to begin to orientate yourself. So if you can find, say for example it's a medial collateral sprain, or you've got somebody who's just got a bit of a meniscal issue, maybe low grade thing, or a bit of early knee OA. If you can find the joint line, that's really useful. So that will give you a little kind of marker to work from. So that hopefully is sitting over the.
And you're just going straight into it. Yeah.
Just rest it on. You won't find your way into the knee joint. It's too close back, but you want to rest on it. The actual line of where the joint flexes and articulates. So once you're there, you're happy that you're more or less in the right spot. Older patients really get on well with this. If you trace along the joint line, you might have 2 or 3 like this. So you've got kind of a line just resting on there, and then you can go, okay, I know where I am, but you can treat the other ends. Say it's a medial collateral, which you'll see plenty of. There's a point up here, and I've forgotten my models again, but you'll have to maybe look on your phones or something. There's just on the condyle there, you've got an insertion point for the upper part of the ligament. So this will make sense when you see the shape of this, and then you've got the other inferior part of it just underneath the condyle there. But fundamentally, just push your fingers in along it, and when they go ouch the most, that's my philosophy. But relatively foolproof most of the time. Now, so that's the inside of the knee, and that could quite easily be a lateral issue, but you'll see more on the inside than you will the outside. So principle will be the same. Just trace along the outside line, and then if it's a lateral collateral strain, it's just shorter and narrower, so you'd have them closer together, and also nor does it attach to the meniscus, which the medial ligament does. So that tends to be, that first needle is one that's really useful. So, and then we got a VMO usually that decides to disappear any knee injury. So you'd have, again, that's where the electrostim is handy, because actually you might got one handy. I might show you. This will help with your bursitis as well, because it'll actually help kind of create a bit of a draining effect on the knee, and I'll show you what to do with the bursa next. And just shape the needles to the shape of the tissue. So the VMO is coming in this way, so you could go straight in, but you'll actually get more of the fibres and a bit more of a grip on it if you follow the course of the muscle in towards the knee there. So we'll just give that one little feed here. see how useful that can be. I'll do that in a sec. And then you've got clear bursitis here, so you know you're absolutely okay to go. Okay, I've got a big pocket of fluid here. I'll do this with the elbow as well. The Lecranon bursitis, same principle. Find the soggiest bits and just drop a needle in. There we go. Okay, there, Glenn.
Yeah, no problem.
Good on that. So just maybe there's another nice.
Stick in another few then.
Yeah, there we go.
Punctures.
Yeah, well, you might. you don't
Baker
wanna
cysts at the back too.
Well, Baker cyst, no, because you've got the popliteal artery in
Okay.
a way. But indirectly, Baker cyst is an extension of a fluid build-up in the knee capsule. So if you can affect
At the front.
generally the knee,
okay.
if you can drain it, you'll find that Baker cyst recedes anyway, indirectly. So you kind of treat it that way. So put a few
So you
in
could
there.
treat it from the front really, is that what
You
you're
treat
saying?
it, yeah, you treat it as a
The
reservoir.
whole
really.
joint, yeah.
So if you get the reservoir starting to move
Yeah.
upstream,
Yeah, yeah.
then you'll find that the Baker cyst
Juice.
not so apparent. Yeah. So those are on top of the actual patella, but there's, you know, when you get your arthroscopies, there's two little eyes of the knee. So if you've got any retropatellar stuff like condromination patella, anything like that, there's a couple of little spots here. There's a bit of fluid around it, but you can just use those eyes of the knee. To
And then you're going
find-
kind of underneath the
Yeah.
patella.
and it's really useful. And then we got you've got plenty of needles going on up there, so you might see this where there's a bit of fluid in around anyway. And you'll see there was older patients usually have a little pocket of fluid here on that odd facet. You're seeing that at the top of the back of the knee, superior lateral kind of facet. You get a bit of accumulation of fluid, so you could drop one in there as well. The principle's the same. And then we got good old-fashioned patellar tendonitis as well. So you'll see with the Achilles when we do it later. So just make sure there's a tibial tuberosity. A lot of people will have, you know, when you're palpating here,
Yeah.
lower ball, it's ouchy. So just try and get as much of the tendon as you can. So you back away, and a bit like the malleoli earlier, you want the needle tip to be
You like
close
that one?
enough to the. Yeah. So that's an example. I'll probably have two there usually. So
You're not on the tendon though.
I am, yeah.
Around it, are you?
Yeah, right along it. Yeah, it can be really. If you've had a long-term issue, it can be you'll feel the grittiness of it. You get, if it's a tendinopathy, it's gone past an itis, so it's into 12 weeks plus, and it's an opathy. It's a tendon condition. Is you'll find that what you want to do is induce a minor inflammatory process, because what's happened is it's got stuck in the fourth phase of healing, and it just keeps laying down collagen and keratin and all those little things that create scar tissue. What you want to do is you want to induce a change, so the little micro trauma of the needle is enough sometimes to flick that healing process, and then you also have a good effect on breaking down that matrix of, you know, tissue that you're getting a problem with. Yeah, because there was a big debate around the sports medicine thing about what has a therapeutic effect when you're getting cortisone injections. Is it the cortisone or is it the
injection.
needle or the injection
Yeah.
site itself? And there was difference in opinions. Guys that have used cortisone forever, guys were saying it's not. It's the microtrauma of the needle that has the
Placebo
effect.
with saline
And
and
placebo. Yeah, you could absolutely. Yeah,
That's crazy.
yeah. In fact, where dry needling came from was you know the Travell and Simons thing.
Yeah.
They started to do that, inject trigger points with saline solution to activate them.
Yeah.
And they thought, well, you know, do we need to squirt this stuff in? Can we use one of these
Yeah.
for a trigger point? Hence, it became dry.
Yeah. Okay.
That's where
Yeah.
that whole thing came from. So, where are we? And there's one really good pain point here. We used this one here. That's liver 3. We used this one, pericardium 6 yesterday. We got this one, large intestine 4. There's another one they do big research studies on, right on the top of the tib anterior there. And if you see on your notes, it's 3 down, 3 finger widths down from the lower pole of the patella, and 1 lateral ischial tuberosity, right in the tib anterior. And I think the reason why that is perceived as particularly influential is 7 interfascial planes lock in there, just all lock in at that spot, and it's really, you can really kind of induce a bit of, it's probably become a blur now.
Is that kind of the head of the...
tib anterior, so if you, sorry, there you go, see that?
All right, yeah.
There you go. It's in the top pocket of it.
Is there anywhere in the knee that you wouldn't use
Popliteal
needle?
fossa.
Yeah.
And the back of the fibula head. But
Yeah.
if you're, we'll do runner's knee later on, but if you got, you know, at the end of the ITB, You know, if you've got runner's knee, I've got one needle left, so I'll show you. We'll kind of do that on the hip, but it's more local to the knee that is an issue. Now you get this sort of, do you see that kind of proper runner's knee?
Yeah.
So same thing. Just think about the shape of the tissue and where it's a little fat pad underneath. So you'll have this little area here, and sometimes you'll actually bend the knee or hear crepitus as it's like the sheath over the top of it. But you want to influence it by running down the last little bit, just on the epicondyle there. So you might have a couple running down the sometimes I'll have 4 if I'm treating it locally. I have 1, 2, 3, 4 there. So it looks like, right, let's break this down. So we've got retropatellar, patella tendon, stomach 36. We've got these because they're in the bursa, and hopefully we'll just mobilise those a little bit. Runner's knee, joint line, really important, VMO, and then we've got medial collateral ligament.
Are you going to turn that thing on to see the...
I am, good point, yeah.
To see if he has a VMO.
Thanks for reminding me. So, thanks for reminding me. Oh, frequency needs to be right. Let's see. Nothing occurring yet.
There we go.
There she goes. Lovely. So you get this. I would definitely do this with a bursitis because you get a squeezy, pumpy thing going on. There you are. That's good. And your nervous system will be well tuned into what's going on here because this is an inflammatory response. So your brain is going